Hello and welcome to the professional webinar. I'm Nurse Linda and I'm here with Dr. Raymond Onders, who is the chair of the Raymond Chair in Surgical Innovation. That's quite a title. I like that. We'll have to talk about that. In the Department of Surgery at the University Hospitals in Cleveland Medical Center. He's a professor of surgery, and he does general and gastrointestinal surgery. But today we're going to talk about something very, very specific. So welcome, Dr. Onders. It's lovely having you here.
Thanks for having me. It's a pleasure to be talking about something that's near and dear to my helping spinal cord injured patients breathe.
And nothing could be more important than that. And also you have this title as surgical innovation. So can you talk more about what that means and what that does?
Yeah, so innovation is something we're trying to help people with new technology. So over 25 years ago, I began this project of diaphragm pacing for spinal cord injured patients to help spinal cord injured patients with a catastrophic injury get off the ventilator. And so that was an innovative idea, doing it a different way over the years. And so that took several years of research before we even did our first human patient. And so that's what innovation is. Sometimes it takes many years from the laboratory to humans and working on different concepts of it, and then getting it to simplify it, which really we've been able to do that for this diaphragm pacing project over my last 25 years of working on this.
So 25 years is a short amount of time in healthcare, but a long time for people who are waiting for these innovations. But still, the innovation is here today. So we thank you for that. So now, what made you think, I think I'd like to help people with spinal cord injury or paralysis breathe? What brought you to the realization? How did you kind of get hooked into this project? Was it something that just came to you in the night, or was it years of study? How did you get involved in this?
Well, that's a great question. And there's always a team involved. And so at Case Western Reserve University, where I'm the professor at, we have a very active functional electrostimulation group. And people that have been around this way for a while remember the freehand system that was also developed at Case Western Reserve, where we put enough electrodes in to move a hand or an arm and help patients. So we've had the infrastructure at Case well before me. And my mentor was Tom Mortimer, who actually really had the idea for this. And I was kind of translation. So there's an idea, then translation to human is where I've been involved in identifying the ways that we can use this technology, not only for spinal cord injured patients, for many other patients to help them breathe. As the American Lung Association says, and as we learned through the COVID pandemic, if you can't breathe, nothing else matters. And that when you've had a catastrophic spinal cord injury, and we know over 70% of all patients at the time of their injury have an endotracheal tube, a breathing tube inside them. That's the initial aspect where you know something is not good. And trying to shorten the time for anybody on a ventilator has been part of my work over these 25 years also.
And you mentioned the Cleveland FES Center, and for people who listen to my webinars, they've heard that before because it's such a phenomenal place. I talk about it all the time. And I remember the freehand system when that came out, and where I had worked, we had implanted several of those in different individuals, which gave people a lot of hand function and improvement. So that was really wonderful. So now you've got this new device for breathing, and can you tell us about that?
Yeah, so what we identified, and this is going to muscle stimulation. So we identified, instead of a system that's been around, the Avery system that works well, you directly stimulate the phrenic nerve, but we wanted to figure out a way that if we could do something a little bit differently to allow earlier implantation, that allow patients to get off the ventilator earlier, which is using an intramuscular electrode that indirectly is dependent on that phrenic nerve. So whenever we do any type of muscle stimulation, be it a TENS unit and an FES bike and all these other things you've talked about over the years, the electrostimulation we believe is very important for rehabilitation in spinal cord injured patients. This is just one muscle that I've really been focusing on, the diaphragm. And so if you have a high spinal cord injury, and this is kind of the basics of it, is our cervical spinal cord C3, 3, 4, and 5, our mnemonic that we teach medical students is 3, 4, and 5, keep the diaphragm alive. And so that area of your spinal cord has branches to your phrenic nerve that goes along your chest to your diaphragm muscle. If your injury is anywhere in that area of your cervical spinal cord, you now can no longer control your diaphragm muscle. And therefore, could we bypass that lack of control by stimulating the diaphragm muscle specifically? And we identified doing that laparoscopically. So my background is as a laparoscopic surgeon. I was in the United States Air Force for several years before I came back to university hospitals in Case Western Reserve. We really identified in the late 1980s and early 1990s that minimally invasive surgery is a significant new technology. Using the small keyholes through your belly button and looking at your diaphragm muscle would allow us to place these electrodes a lot more easily than through the chest, which is the other way that's been available. And so we identified what can be done laparoscopically, and going from an animal model to human model and all the FDA regulatory aspect can take years, as you mentioned. A new innovative technology on average takes about 17 years from concept to becoming the standard of care. And that's really what we started with our first implants in the year 2000, the first human implant. And as we all know, and if people in the audience don't know, is Superman, Christopher Reeve was the second patient I successfully implanted really 20 years ago at this time period. And so that's why it's such an honor to be involved with this organization over all these years.
And as we spoke earlier, I was there when you did that, which was pretty exciting. So that was one of the highlights of my career. But you talk about the diaphragm being one muscle that you're innervating, but it's a pretty significant muscle when you think about what it's doing, because breathing is, of course, essential. So you talked about the laparoscopic procedure, and for some people, surgery seems kind of common for a lot of people, and they don't really think about the differences between an open surgery and a laparoscopic. So could you talk about why laparoscopic is so important, especially in this population and doing this procedure?
And I think you bring up good points of when you've already had a stress of a major spinal cord injury, trying to decrease your body's inflammatory response by doing a larger operation is key. I think one of the key things we've done over the last few years is identifying doing this very early after injury. I know we had talked previously, and for the audience, I just published a recent paper that just came out several months ago showing we can do this very early after injury. In my trauma hospital, after your spinal cord injury and you're stabilized from that catastrophic event, we'll actually do this surgery within 48 to 72 hours after your injury. Same thing when we think about fixating the spine to help you get better faster. If we realize that you have a very high spinal cord injury and you're not moving your diaphragm muscle, we can add this minimally invasive surgery to implant these electrodes and help get you off the ventilator very rapidly. And I think that's the key thing about why it's important. So we all know that surgery, you're always questioning doing another surgery, but being on a ventilator is really the most catastrophic problem that we have in high quadriplegic patients. And so, and I think we'll probably talk about during this time period, I now have had 40% of patients in my trauma hospital with a high spinal cord injury, we don't even do a tracheostomy. And I'm pointing to my neck here because I was operating. And so, many spinal cord injury patients need the tracheostomy to help control the airway. You can't keep that breathing tube in. And I think a lot more people realize the problem with breathing tubes during the COVID-19 pandemic when we had a lot of patients on ventilators. That really changed my thinking, in 2020 when this pandemic started. I know many spinal cord injured patients, and I kind of talk about this, were worried, I'm a high quadriplegic on a ventilator. Am I worthy to have one of these limited ventilators when I'm a quadriplegic? And one of the things is that we can get you off the ventilator and use that ventilator for other people during that time period. I think getting off one machine, at least using your own muscle, what we call negative pressure ventilation, when we're using diaphragm pacing, you're using one of your own muscles, your diaphragm muscle. When you're on a ventilator, that air is being forced in to your lungs. It's what leads to barotrauma, which leads to almost a universal, about 80% pneumonia rate for a high quadriplegic in your initial hospitalization. And trying to decrease that by doing this very early is really an important aspect. It's really such an important aspect that the American College of Surgeons Committee on Trauma, which kind of controls all level 1 trauma centers in the United States, as of 2022, it's in their guidelines now that diaphragm pacing should be utilized on spinal cord injured patients early. Because one is we realize having a patient get off that ventilator. It's the first step to what I consider the most important thing for a spinal cord injury patient, more aggressive rehabilitation. When all you're doing is trying to get off the ventilator in ICU, is all those other aspects of your injury that we have to deal with. That, Linda, you've talked about so well in your webinars over the years, every other aspect of bowel bladder care. The first step is getting off the ventilator. And that's why we've really worked at showing that it's very safe to do this early. And it really gives the best benefit to patients is doing this as early as possible if you're on a ventilator after a spinal cord injury.
And do you think it would be at some point in time possible to do it at the same time as a stabilization surgery, or would that just be too much at once?
We have at times,
All right.
but many times it's kind of switching the patient back and forth. We do know that very early spinal cord stabilization is important. The earlier, the better, to try to decrease the swelling and help that process of your spinal cord injury. So we usually wait until that operation's over and you're still in our ICU. And then we can consider whether or not we need to do a simultaneous feeding tube to help clear your mouth and everything, so you can use the cough assist more easily, and these other tools that we have for secretion management. So that's something that we look at it is doing it. Yes, I have done it at the same time, but usually I'll get that stabilization done, since that's a bigger operation. They don't do that minimally invasively. And then, within a day or two, once we've stabilized from that, we'll consider, and we'll make sure that the patient doesn't have the possibility for being weaned off on their own. And that's kind of, and I'm sure this will come up in this, is that everybody says, how do we know if you're a candidate? And there's no test to know except that laparoscopic surgery. What we know, and unfortunately in the United States, we have a gunshot wounds is an increased incidence of our spinal cord injuries in the United States. That changes your spinal cord if you have a gunshot wound, because what we call the blast injury to your spinal cord column. And so some of those patients we cannot stimulate, and then we cannot wean them off the ventilator using diaphragm pacing. But the earlier we know that, helps the patient on what's going on. And I've said this on numerous aspects, is the worst thing, and I've seen patients that sometimes get transferred to me after a month, and they're every moment they're trying to wean off the ventilator. And so you think like you're trying to breathe, but if you can't move your diaphragm, you can't be weaned off the ventilator. And then sometimes patients say, it's like I'm failing every day to get out. You're not failing, you just can't get off without an added boost of electrical stimulation. So therefore, that try every day to be weaned off the ventilator and fail can sometimes give a patient, in the face of this catastrophic spinal cord injury, and you've talked about the complexity, the depression, what's going to happen, to at least show that we can get you off and that you haven't been failing. It's not your fault that you're not getting off the ventilator, it's just your injury. And so that gives a little help for these patients, knowing that we can help them with electrical stimulation early. Or if we can't wean them, we stop trying to wean. So it gives us this aspect of that we're going to change your ventilator, and we're just going to use what we call higher tidal volumes to prevent atelectasis. That's kind of our concept, that we're trying to do this early on patients. And now that the American College of Surgeons, that controls is a guideline, any patient out there that hopefully nobody will listening will have a spinal cord injury in the future. If you know somebody that has, they should just ask for diaphragm pacing early, because that's the best way to get you off that ventilator, prevent that first pneumonia maybe, and allow you to go to rehabilitation hospitals, which is really so important for getting back to what we want for you, is being interactive with everybody else in society after this catastrophic injury.
And how wonderful to cut down on all those respiratory complications, because that does hold people back. It sends them back to the ICU. It sends them back to the acute care hospital. When they're at home, it can send them to the hospital. So it really is critically important. And that you've developed this way to help reduce that. So now tell me about the device. What do you call it? Does it have a trade name?
Yeah,
how does it work in the body? How does it go about working?
That's a very good question. So this is what we call a percutaneous device. So you have electrodes coming through your skin. Like many things, you may have a gastrostomy tube, a suprapubic catheter. Hopefully, we get rid of the tracheostomy, which is kind of the most dangerous of all the tubes, is that tracheostomy tube. And so then it's an external pulse generator. The name of it's called NeurRx. It's made by Synapse Biomedical, which came out of my university here. And so, commonly known, I just call it the diaphragm pacer. I don't even call it by its trade name, but it is called NeurRx, capital RX, and it's actually Synapse Biomedical is a company that manufactures it. And probably, I think I'll mention this is, at the beginning of the pandemic, we began working very closely with FDA on changing this a little bit. This has been approved in the United States under a humanitarian device exemption since 2007, 2008, but you had to have an IRB. It was an FDA kind of very old regulation for, it's completely approved, it's safe, but because of the orphan disease, as we all know, spinal cord injury is kind of an orphan disease. When you're on a ventilator with spinal cord injury, there's only about 1,000 new patients a year with that injury that can't get off the ventilators. So it's a very small subgroup of patients. So the FDA has a program that's a little less expensive, a little less tedious to get it approved, but did require this old IRB. And we began working with FDA when we realized, and I realized early in the pandemic, that it was harder for patients to be transferred from state to state when there's no ICU beds. And so therefore, I'm working very closely with FDA that allowed us to just this year, the FDA agreed that our data is so strong with real world evidence that it no longer required that IRB. That means that any hospital in the United States can now order this at any time early after the patient's injury. And that's kind of what is important, is that we realize the earlier, in my mind, is the better for the patient. Now, I always look at the patient first and not the cost, right? It also saves about $150,000 by doing this early. And then it saves the annual cost of a ventilator, which really approaches $200,000 a year to be on a ventilator, the cost for that. And so by getting off the ventilator with this device, and the device is really, it's about this big, the size of a cell phone, but a little thicker, and it connects up to the patient. It uses disposable batteries now, which is just a regular C battery. So you just change the battery whenever it goes down. And that allows us to also not worry about electricity. And so we all realize, and this goes back to, obviously I've been doing this for so long. I remember Hurricane Katrina, when a patient waiting to get our device, and I had a patient with our device. And so the problem with hurricanes, as we all know, is lack of electricity. So what is a ventilator dependent on is electricity.
Right.
So officially, to go home on a ventilator, you need a backup generator for continuous electricity. When you have a diaphragm pacing, our batteries actually, our lithium batteries last 30 days, our alkaline batteries last 7 to 8 days. So therefore, if it's just a couple batteries, you have a month's power supply to allow you to breathe. So, unfortunately, we still have blackouts to this day. Obviously, unfortunately, Florida just suffered a massive blackout with the last hurricane. So when we think about the complexity of being on a ventilator, the smaller device that controls your respiration by stimulating you 12 to 18 times a minute, really simplifies the care for you at home. And it's probably safer with this lack of electricity needs.
Well, that's you brought up several marvelous points there. And so I think for all our listeners, as you said, if you have a patient that comes in or somebody who has one, be sure and suggest this, because my goodness, it's such a difference. And you were talking about the financial savings, but also I have yet to meet somebody who had a trach and was ventilatory dependent that didn't find that the trach was so bothersome. So if you could get rid of that trach, boy, what a load that is. And now the electricity thing, that's really wonderful, because we do a lot of education about, talking to your power company, we're on a ventilator, notifying the EMS, there's a lot to be taken care of, buying another generator. There's a lot to be done. Now, I know that you can't specifically say a particular individual would qualify this or not, because you said you have to look and see if they are responding before you hook all this up. But there is a person who writes in and he says he's a quadriplegic due to radiation for a cervical spine tumor. And he's watching the respiratory from a respiratory rehab. He was placed on a trach after not being able to maintain his O2 levels. And he's struggling to wean off the ventilator because his stats drop very quickly. So and then there's another person who wrote in that they have a neuromuscular disorder. So would either of these people qualify, just in general, because I know you can't speak to the individual, but could you talk about those different diagnostic categories that this might work for?
So spinal cord injury was our initial kind of indication for this, but we've used it in other patients. And I think the spinal cord tumors, which is not a traumatic spinal cord injury, but many times that also disrupts what occurred. And radiation is very interesting. Radiation causes a neuropathy. So I have several articles coming out that have been published already about a unilateral diaphragm dysfunction or an injury to a phrenic nerve. So remember, in trauma, you may have a spinal cord injury, but you can also have an injured nerve, such as a brachial plexus injury, or an injured phrenic nerve because you may have had a lower spine injury where that nerve, which is in your mediastinum, gets injured. So physical therapy helps any nerve to recover, even after radiation. Functional electrostimulation as physical therapy, such as a TENS unit, helps nerves recover. Diaphragm pacing for nerves that have been damaged by radiation or by other aspects will help that nerve recover significantly. Now, we've seen that very commonly after COVID-19. And so you can develop a phrenic neuropathy. So you'll hear of this breathlessness after COVID. So people are short of breath. And for a subgroup, about 5% of those patients, they have a nerve that no longer works. It's a neuropathy because of that virus. And you can get it. We had a term for that before COVID called idiopathic. So people could get a shingles and have their phrenic nerve involved. They could get just some other West Nile virus and their nerves can get that. So some other viruses can cause a neuropathy, and physical therapy helps that nerve recover from that neuropathy. And so when you have one diaphragm, this is my diaphragm hand puppet. So when one diaphragm is working, another one's not, it becomes elevated very rapidly because it gets stretched out. And so what we know is that if we start pacing a patient, and that's why radiation comes in, because we know that during radiation or during mediastinal surgery, a chest surgery, you can have an injured nerve too, that we utilize diaphragm pacing to help those muscles get stronger and the nerve recover. In neuromuscular disease, there's a small group that this does work in. And this goes by to if you have what we call lower motor neuron disease or an upper motor neuron. And so if you cut a phrenic nerve completely, that's the complete lower motor neuron injury. Or you heard me talk about if I have a gunshot wound to my neck where I blow away all my motor neurons that control the phrenic motor neurons that control the diaphragm, is we can't stimulate a muscle without an intact nerve. So if you have, for example, ALS, we've done studies on ALS, there's a very small subgroup of ALS patients that are mostly upper motor neuron involvement, which their cerebral cortex can't control their phrenic motor neurons, then diaphragm pacing will work. So it's a very small subgroup of ALS patients. Now, there's a lot of other neuromuscular diseases, such as Pompe's disease. Today I just implanted somebody from Minnesota with a very rare VSP myopathy that we were successful in today. So there's a lot of neuromuscular diseases that are rare, such as SMA type 2, this will work in. And that becomes a much more orphan diseases. And so I'm an expert in these very rare orphan diseases that will assess that. And sometimes the only way to know for sure is that we look in laparoscopically. If we can stimulate the diaphragm muscle and get movement, then we can help somebody get off the ventilator. And so for brainstem tumors, we've done a large series of those actually, and especially with the radiation, which has some lingering side effects, can affect the nerve, and therefore we can stimulate those patients.
So you go in and you look, is there's no outside test that would say, like an EMG or nerve conduction study that would say you have to look in there?
Well, we used to do that on every patient. So I published an article 4 years ago where I would do a phrenic nerve conduction study where you stimulate the nerve in the neck and see if it works. But there's a high false positive and a false negative. So that means the study says, oh, this should work. And I go in there and I say, it doesn't, your diaphragm can't be stimulated. And the flip side, there's patients that somebody said their phrenic nerve conduction study isn't good. So I said, I'll still look laparoscopically. And I had a perfectly good diaphragm to stimulate. And so being on a ventilator changes your survival so drastically that it's worth doing a diagnostic laparoscopy. And even, I do remember, Christopher Reeve saying to me, you probably heard this, what do I have to lose? If you're already on a ventilator, doing laparoscopic surgery really has almost no risks because you're already on the ventilator. Usually when we do surgery, we have to put somebody on a ventilator to do the surgery. When you're already on the ventilator, it's a very low risk operation. So that's why I think in my experience of getting off that ventilator changes your life so significantly that it's worth taking a look laparoscopically. So I'd hate to be just because I've had a series of patients where the phrenic nerve study said they were negative, but I went in and we got them off the ventilator. That's really why I published this article, so we have data that shows that really you just need to have laparoscopic surgery to know, and that's really the way to know for sure if this will work or not. And if it, unfortunately, if it doesn't work, we at least know that, and we there's things we can do. I tell patients, and just last week or a couple of weeks ago, I had just a 20-year-old that was unfortunate, innocent bystander from a gunshot injury, and I went in there and I couldn't stimulate the diaphragm. But for 2 months, somebody had been trying every day. He'd been trying to wean off the ventilator, and every day he felt like failing, and nobody had let him talk yet. Nobody had put in a passing-mirror valve. All these little things that we work on, that it's not just the pacing, it's using what we call a passing-mirror valve, getting rid of your cuff tracheostomy so you can talk all the time. And so even though I couldn't stimulate him, I had him talking that day, because I just changed his ventilator settings. And that's a key thing, is that there's people that know I can go to what we call high tidal volume, so you have more air leak, so you can talk all the time. I mean, everybody knows Christopher Reeve used to talk all the time on his ventilator. And so you can talk, and that's part of that is, if your local hospital is not doing that, fine. And most spinal cord hospitals, that do rehab know that. But what we realize, and we realize this, is we all know in the healthcare industry now, there's a shortage of nurses, there's a shortage of people. Not all spinal cord rehab hospitals take people on ventilators. And so you may be at a smaller hospital with your injury, and you're not getting completely right answers on what to do. And that's part of it. And that's so great that, webinars like this, where people realize what can be done, and that there is hope with a catastrophic injury. The first step in my mind is getting off that ventilator. And if we can't, we can still get you talking and getting you to a rehab center that'll accept somebody on a ventilator to get everything there.
And, it is unfortunate because there are a lot of people who are in not near a rehab hospital, or maybe they have the opportunity to go, but they've just been through this horrible trauma, or they're having this horrible disease, and they don't want to leave their family because that's their rock. And so, for whatever reason, sometimes people don't get to facilities where there are places like this. But as you said earlier, this can be ordered from anywhere and put in by anyone, correct?
That's really what I work so hard on with our team at Syneos Biomedical, the company, and the FDA. I can tell you, I have a very good relationship. People may say things, but I work closely with the FDA and getting this approved so anybody can do it. And the American College of Surgeons and the trauma centers where most patients end up, this is not a complex operation. It's a laparoscopic, and we've developed ways to train people. During the pandemic, we did the first 5 implants in Japan, where I over a Zoom like this, I trained the surgeons on how to do this. So our a webinar like this, we train the surgeons. And so it's something that we can help. And it's really been part of my passion, is that, and you really bring it up, if you're far away from the family, that's your rock and that's your help. To have this done locally is so important. And getting off the ventilator does open up more rehabilitation. And I like to say diaphragm pacing is like having a physical therapist working on you 24 hours a day, 15 times a minute, you're getting electrical stimulation. That's probably the other point that I think is so important with this. And we've all heard about a lot of these studies coming out about electrical stimulation helping in recovery. And this is why I really have been so active in doing this early. So we know that electrical stimulation helps patients recover from their spinal cord injury, where they actually have some recovery of function, right? And so when we're using physical therapy, FES bike, it actually helps stimulate your spinal cord in those passageways. So when I look at this, and kind of the article I just published is somewhere up to 40% of patients I implant early, we wean off the pacer. They recovered their own breathing. And this is what is so important, is we know a spinal cord injury, it's not like you cut the spinal cord, right? It's a bruise to that spinal cord and a little vascular insult. And as we're doing all this work, there's some people much smarter than me looking at trying to change that milieu, right? To get more ways past that injury. So I always like to say the phrenic motor neurons are controlled by multiple things above the level of injury. My cerebral cortex, I can think and breathe. But what people forget is in our brainstem, in the lateral medulla, it's called the preboscidal complex, most of us don't think about breathing. It's an automatic response that's in the brainstem. If those passageways are different than how we volitionally breathe, and if we open up any of those passageways to our phrenic motor neuron, patients recover their own breathing. And so I remember the first patient, it had to be almost 15 years ago, that she called me up from California and said, wow, I can frog breathe for 7 hours now. And I said, nobody can frog. Frog breathe is rescue breathing. If you disconnect it from your ventilator, you learn how to breathe and swallow air. As I said, you can't do that. And I checked her out before, and in my research studies, we can read our implanted electrodes, she'd recovered her own breathing. And she was 2 years post-injury. So functional electrostimulation helps open up those passageways of some recovery. And we've shown that in other studies, and you've talked about the FES bike and other electrostim. We're always trying to help. I mean, I've implanted patients 25 years on the ventilator, and we got them off the ventilator. The system's intact, and we sometimes just need to kind of jumpstart that. That's a good thing, jumpstart like a diaphragm pacing, since it's electrodes. And so we can use this to start opening up those passageways and relearning how to breathe on your own again. That's why.
That nervous system is very clever in that regard, that it wants to heal. It wants to make the body the way it's made to go. It wants to do that. And let me just highlight what you said, because this is so huge. So 40% of the patients that you have put this diaphragmatic pacemaker in eventually have recovered the breathing on their own. That is huge.
That's when we do it early. This is the key thing.
Okay,
I think
little
early,
caveat there.
When I looked at my long-term study, it was like 8%. So I published that paper like 6. So now we're checking this. So sometimes we also say, what we look at is not only are we, maybe this patient may have been weaned on their own in 3 to 4 months. In that 3 to 4 months, there's a death rate from pneumonias. And a group in Jacksonville kind of published this, and they showed that before they did diaphragm pacing, a high quadriplegic that's on a ventilator, there's about a 15% death rate in the first 60 days. And this is the unfortunate aspect. You may get your first pneumonia, you may get your first decubitus ulcer. And as we all know, then you get a little septic, and then you get antibiotics, then you get your C. difficile problems, and then it leads to other problems. When they did early diaphragm pacing, that early mortality rate went down to 3%. And so one aspect that we're realizing, so I think somebody may say, well, this patient may wean, it may take a month or two, but what if we wean in 48 hours and then you don't need these electrodes anymore? And that led to a lot of my more recent research. So the same thing, and that's what we do as researchers. We've now developed what we call temporary diaphragm pacing systems that I use in lung transplants and high-risk cardiac patients. The same technology that we've been using in spinal cord injured patients for over 20 years. But we realized being on that ventilator, and really I think everybody started realizing how bad being on ventilators is with the pandemic several years ago. It's still kind of ongoing, but is that if we can shorten anybody's time in the ICU, that really changes everything. That's kind of why at our spinal cord injured patients is that the earlier we do this, it changes your ICU problems. Because I always like to say, and I'm sure there's people on this phone call intermittently looking at chat that have been on a ventilator, and they have to get suctioned all the time, right? And why is that? I don't get suctioned when I wake up in the morning. Do you, Linda? No. Because why do people on ventilators have to get suctioned? Because you have an abnormal way of breathing. You have air being forced into your lungs, and that goes into what we call your anterior part of your diaphragms, or anterior part of your lungs. When we breathe, we're breathing in the posterior part of our lungs. And so that actually, the air goes in there. If you're not expanding that part of your lung, it gets secretions. Now, tracheostomies and then the tracheal tube lead to secretions also. And so that's why the earlier we can start using all your lungs the way that they were meant to be used, then you have less problems with that first pneumonia, that atelectasis, the need for suctioning. Now, as a high quadriplegic, you still don't have a cough. As you know, the FES Center is also working on a cough systems with Dr. DeMarco. And so we have other electro systems that do that, but use the cough assist that Dr. Bach really popularized, that I use in all my patients, the insufflator, exsufflator, to really help those patients. And so these are all these little management things that we try to do to prevent that first pneumonia that can lead to all the other problems. And this is, like you mentioned, the spinal cord injury, there's so many things going on and trying to heal itself. If you get a pneumonia and an infection, that affects what's happening with that spinal cord injury also. So if we can decrease those things and decrease the time that you're on a ventilator, that's going to help, and ideally, the more recovery from that spinal cord injury. And that's kind of one of the reasons that I've been working so hard on trying to get the word out that the earlier is probably the better. I mean, after doing implants for 2 decades, working on this for 3 decades, is the things that we realize is I really recommend early. Now, we still do this 25 years after your injury. We can still get you off the ventilator, which is still something different that will change a little bit of your day-to-day activity. So,
well, now I've not talked to that many people that have one, but I've talked to probably more than a lot of people have. And I know that a lot of people will say that they have a little bit of an adjustment period because they're not hearing the whoosh, whoosh, whoosh of that ventilator all the time. They're not hauling around that heavy piece of equipment. So they can get a lighter chair. They can get, different equipment that's not so hard to navigate the world through. For those that come off of the trach, it's so much more comfortable. So what that you have this experience with a vast amount of people, what do they like and what do they not like about this device?
It's very interesting that you talk about that whoosh, whoosh, whoosh. I have several patients that implanted, 5 or 10 years after their injury, and they're probably injured as young adults, late teens or so. And then what we realized is that you said that they realized that if they didn't hear that whoosh, whoosh, whoosh at night, they were going to die. And you hate to say that, but every year in the United States, people get disconnected from the ventilator and die, even in ICUs, more than a few, because as a high quadriplegic, you can't put yourself back on that. Mm-hmm. So many patients realize our pacing device, even though it's percutaneous, it comes out through the skin, is much more stable. You have the electrodes coming out on your abdomen, kind of across from if you have a gastrostomy tube in that area. It doesn't get disconnected as much as a ventilator, and so that makes them feel more comfortable in this area. And it also, there's this little safety issue you heard me say, is that I've had many patients that when you're dependent on a ventilator for talking, you're hyperventilating because you're talking more, getting that. So your carbon dioxide level goes down a little bit. Christopher Reeve had the lowest because he talked a lot on his ventilator. And so when we go back to normal physiology, there's things we may not even realize. So our carbon dioxide level is usually 40 in our bodies. People chronically on ventilators goes down to 25 or so. That changes your bicarb, changes your urine pH. It may lead to more stones, as can develop in these patients high. So if we can get you back to normal physiology, at least on your breathing, is probably better for you. And the quiet that you don't have. Obviously people are finally going back to movie theaters. And if you're on any older ventilator in a movie theater, everybody knew you're on a ventilator. When you're on diaphragm pacing, there's no sound to it. So it's that little bit, in this field, being a little bit more normal, where people don't hear you, is very important. It really makes people feel, a little more. I may still be a high quadriplegic on a ventilator, but people don't hear me coming because I'm not on the ventilator.
And I imagine you wouldn't see it if you had that under your shirt or whatever.
It's much smaller, so
it's very, very private. That's kind of cool.
Yeah.
So now here's some question, and we're heading to this really big question anyway, but the reader is writing in about can you get this through the VA system? But it follows through with the question, how much does it cost? Who pays for it?
It is.
Can anybody get it?
It is actually approved by the VA. It's on their list for that. Our VA, the Cleveland VA, is a great spinal cord rehab. I'll give a shout out to our VA. And so we implant patients through our VA. It's our region, the regional spinal cord one here in Cleveland. So we do them routinely at our VA. They may come over to see me for a day, then they go back to the VA for all the rehabilitation. So if you're in a VA, just ask to go to the Cleveland VA and they'll do it pretty quickly. And so it is covered by almost all insurances. And it's interesting is that I've had, as we all know, there's a secondary insurance market, right? So let's say you're a workman's comp patient. And all of a sudden you have this expense of $200,000 a year. So I had a workman's comp patient in North Dakota. This is before we had the can get implanted everywhere. And the insurance company called me up and said they'll fly them to me and implant them. A flight of a patient on a ventilator, as you know, can cost like 50, 60,000. And so the device itself is relatively, in that aspects, less expensive. So it's covered by almost all insurance companies now for spinal cord injury. Some of these other things, it's because it's very cost effective. And it's now in the guidelines for care from the American College of Surgeons. So it'd be very hard to not offer that if a patient asks for it. But this is still an orphan disease. I'll be the first to say, has anybody ever seen a TV advertisement for this? No. Have you seen any advertisement? Orphan diseases, and Linda, you're familiar with the freehand system kind of went bankrupt. So, this is a system that we think you have to manage it correctly, do it ways through this and have people realize it's available so that one, it's always available for these patients for all time. We only wish we didn't have any more spinal cord injuries, but we all know that that's not happening. And so it is covered by almost every insurance carrier, and it's actually on the VA. Just like 3 months ago, it's on all VAs can implant this now.
Well, I think all of us that work in spinal cord injury, individuals with spinal cord injury, I think we all would love to wake up one morning and there would be no more trauma, no more disease, and that would be just fine with us. We would go do something else. But in the meantime, we'll do what we can. There's a question from somebody who says they have an Avery phrenic nerve stimulator for 21 years, but their doctor's retired and they haven't been able to find somebody that can help with that. And so the question is, you've already answered the question that you can get this. You don't have to fly people to your facility anymore. Somebody could get it wherever they are. So that's a wonderful thing. But do people know and understand how to use it once they have it implanted and now they're in a different location, maybe away from? How's the access to medical care? How hard is it to use?
It's actually just 2 buttons to turn on and off, and that's
all right then.
So there's an on and off, and the Avery system does work well, as the person said, for 20 years. It's been around since 1969, developed out of Yale. They both work well, and my goal is that more people getting off the ventilator is good, either with direct phrenic nerve stimulation. That's usually done with the neck incision or chest incisions, and that works well too. The key thing that I look at is the difference between the two is how early you can put it in. I'm really trying to, for early patients, they both work just as well. So I've had patients that they don't have a percutaneous, it requires a battery pack external like either device, but they both work well. But part of that is trying to get this into more people, and that's kind of been my goal, being very active in this for so many years. Is now we're using it, the same technology, but multiple other indications, open heart operations, lung transplants. And that's part of that, is that trying to get people used to this technology in all ICUs so that we can help everybody get off the ventilator, which in turn helps the spinal cord injured patients. So more people will utilize this device in all areas. And there's a variation in the country. In Florida, just about every spinal cord injured patient gets this, and in Ohio, everybody does, because I'm in Ohio. Certain areas nearby do. Certain centers are very active in it, being Shepherd, Craig, Northwestern, the Riley Center. And actually, we're utilizing this in some pediatric patients going to Johns Hopkins Pediatric Center. But other areas, there's not taken off like we'd like, because it's still a relatively rare. But I think, and again, it takes time. Only in 2022 did the American College of Surgeons put it in their guidelines. We're a little over a year with this. We're only 6 months since they had full FDA approval. And so this is kind of the process of trying to get people to realize that this is an option for spinal cord injured patients. And I think that's what this webinar is good for. And obviously, we do a lot of work on trying to get the word out of there with publications so people know about this. And the more people utilize it, the more people have experience with it, which is very important. And that's kind of one of my goals, has been to utilize this to help other ICU patients on the ventilator also.
Well, and that's the point of these webinars, is to get this information out to people, because it's very hard to cross that link between healthcare and for common people to know, hey, this is available to me. I would like to have that. There is a question about infection, since the wires are coming out the abdomen.
Yeah, is
that a problem,
device. No, the electrodes were designed to get tissue ingrowth, there's always, anybody that's had a feeding tube can have an infection. And I like to look at it this way. The worst thing that can happen is if you have a tracheostomy. A tracheostomy can lead to tracheomalacia. So there's a significant death rate from chronic tracheostomies from what we call bleeding and erosion of that tracheostomy tube. And so even if we get a small skin infection and we've gotten rid of the tracheostomy or gotten rid of positive pressure ventilation, that's a good aspect. We know when we looked at a European study, looking at patients with either phrenic pacing or diaphragm pacing versus those without, on average, if you're on a ventilator, you get 2 pneumonias a year from being on that ventilator. With diaphragm pacing or phrenic pacing, you get 0. And so there's no risk-free process, but there's less risk from that skin infection. It's very rare. I've implanted almost 900 patients now. And so we've had, I've only had one patient I think I ever had to take the electrodes out of and reimplant new ones in. But besides that, it's just a superficial wound infection that you may get around your gastrostomy tube, your suprapubic granulation tissue. But that's been about it. But the goal is not to get that catastrophic infection, which is pneumonias. And so.
And those infections that you described, they're pretty unusual, really, and very treatable or in early, so it's not like it's a huge invasive kind of like the pneumonia, which is inside your body. This is more superficial, so that's good. Somebody was wanting to know, they're in Florida where they can get this device, but they put their city in there, but I've kind of lost their question here. Oh, Fort Lauderdale. So you mentioned before where would you go if you were in Florida?
There's about 4 different spots, Jacksonville, Gainesville, Orlando, and down in Miami, there's a recent hospital that I was just down there training the surgeons. So I'm actually blanking on the name of the hospital, but if you go to the Center for Biomedical website, they list all the hospitals that actually do this and actually can help patients find this technology nearby. Now, I'd love to come to Florida, let's say in January, and do your surgery, because then it's really cold up here in Cleveland. And so that'd be my preferential thing. You don't want to come to Cleveland in January for your surgery. Now it's nice, it's fall. So it's good time now. So
Yeah. But if you were out someplace and you went and talked to your doctor, at your regular healthcare practitioner, and you said, I heard about this thing, this diaphragm pacemaker, and I want to get one. And the doctor says, oh yes, we have somebody who does minimally invasive abdominal surgery here in our hospital. Then would they contact you to contact the company to say, we want to do it here in our own facility, and you would train them, or you have a training video or something that does? So it's not that difficult to have it done right where you are.
No, that's what I think. I think you brought this up. I think it's so important for family. And there's other aspects that I bring up at times. And so one aspect, as we all know, is that sometimes you have your full-time nursing staff that take care of you. And if you have to come to Cleveland for 2 weeks, your staff isn't going to get paid, because you're not down there. So I've had patients say, okay, I'm going to do the surgery and I got to get right back. I'll do my weaning at home, which we can do, because I don't want to lose my staff that I've had. Because insurance companies won't pay for staff if you're not there, the patient, that is, right?
That's
so
right.
It's very important. So, I realize how important that is to keep the people that you've got, your team around you, to help you in all activities. So we'll work with that. And that's why we'll do the weaning at home. Instead of weaning you in 5 days, maybe it'll take 30. And that's what we really designed is, if a chronic patients are at home on a ventilator, you can wean off a ventilator at home by yourself. Using this technology. We've actually have an entire program for that where we slowly increase how many minutes. And that's, if you've been on a ventilator for 10 years, your diaphragm muscle, and this is the diaphragm muscle is so dependent on utilization that you will lose 50% of your diaphragm muscle mass in 1 day of being on a ventilator. Your diaphragm muscle is made to work every minute of every day. And if it's not doing that, it converts to what we call type 2B muscle fiber, fast twitch muscle fiber. So our diaphragm is kind of like a marathon runner, where it's made to work every day and it doesn't tire out unless you go on a ventilator. Then it'll convert the sprinting muscle, which will tire out. It's like if I tried to run a mile, I'd be like puffing. If you've been on a ventilator for a little time, your diaphragm won't be able to give you that good strength. So we have to strengthen that muscle to get you off the ventilator. And that's what part of the weaning process is we utilize this. If you've been on a ventilator for a while, 30 minutes a day, then 60 minutes and 90 minutes. If we do this early, 3 to 4 days after your injury, we just turn it on and keep it on. And we wean you off the ventilator within days. That's kind of why we're pushing for early, but we'll still work with people in a program, even though you've been on a ventilator for a decade or 25 years.
So you have a process and it's variable for everyone. So it's not like you put this in and boom, it's on and you're just breathing. It's a little bit of a process.
To recondition the diaphragm muscle and your lungs. If you've been on a ventilator for a while, you've probably had several pneumonias, you've had chronic collapse and part of that. So we're rehabilitating your lungs from what we call the barotrauma of positive pressure ventilation. Our entire body is based on negative pressure in our chest. That's how we suck air in. When you're on a ventilator, it changes the entire physiology. I mean, we know your heart doesn't work as well when you're on a ventilator. We know you require more fluid initially after your injury. So when we go back to more natural negative pressure ventilation, your heart actually works better in that environment. That's what it was made to work in, right? It's not made to work with this pressure of your ventilator, always forcing air down into your lungs. So it changes the physiology, which is, again, part of this concept of getting your entire body back to a little more normalcy, which is important when you had this injury that, as we all know, and you've done so well in all of your talks over the years, it affects so many different things, your spinal cord injury. Mm-hmm. If we can get you off that ventilator, that's one aspect of getting your body a little bit back to normal physiology.
Yeah, getting off the ventilator is huge. It's critically important for lots of things. There's a question from somebody about pediatrics, and you had mentioned pediatrics earlier. Do you have any special words of wisdom for the pediatric patient?
Yeah, so this is what we call off-label use of an FDA-approved device. So it's I've done children. I mean, I've done a 1-year-old spinal cord injured patient. The system works the same. We do utilize a much higher respiratory rate, so we have to make little changes to that external pulse generator. Now, this technology, which is the same diaphragm pacing, I've now used in our neonatal intensive care unit to help children get off the ventilator. I use our newer electrodes called the Transaris, the temporary electrodes, which I can place a little bit more easily in these patients. We are going to work closely with FDA to get this approved for children in their official FDA approval, but then you get to a much smaller orphan disease group of children. So it's a much smaller area. But I'll be presenting at the International Spinal Cord Injury Association, our last group of, I think, 40 children that we've implanted. There's several sites doing children across the United States also, though. So we have one, Johns Hopkins had been doing some in the past, and Illinois, the Children's Hospital of Illinois has done a series of them. And I've seen many people work their way to me for children. But even in Florida, they've done some children now also.
Well, even though it's off-label, 40 children that you have done and all these other places, it sounds to me like that's a pretty fair number of people that have pediatric patients that have had that. Just a comment, there's a comment in the chat box that for the person looking for care in Florida, there's an invitation from Brooks Rehabilitation Hospital in Jacksonville, Florida. They're inviting this person to contact them. So we've made a connection.
Oh, they are they're an excellent rehab hospital. I've had my patients go there over the years, and I think they've just published their results on diaphragm pacing too, how they manage the patients. So it's a great group of one. I always like that the total rehabilitation. I'm a simple surgeon. I just work on one muscle. These rehab doctors have to work on all the other 200 muscles in the body. So I'm just a one muscles rehab doctor.
Well, I have to say, it's just kind of funny because you say just this one muscle, but as I say, it's a very important muscle, so we don't want to overlook it. Now I'm going to ask a far out question just because I'm curious. Do you ever envision a day when people aren't on mechanical ventilation for any reason at home?
It all depends. Unfortunately, there's certain diseases such as ALS where you don't have any muscles to stimulate that you may need that. There's certain, if you've injured the phrenic nerves and you can't get recovery, but we really look for, I've done some post-polio patients going back. I think SMA2, we've had some work on Pompei's disease. But it really becomes, this is part of the problem of research and rare diseases. So you have a group of 10 or 20 patients at home ventilators. And the way I look at that is, if we can stimulate your diaphragm muscle, then we can get you off the ventilator, because that allows us to bring the air in. And that's kind of our concept of looking at all these rare diseases that people are in home mechanical ventilation on. And really, the more important thing is, can we, in the United States, we said there's about 1,000 high quadriplegics. There's 100,000 tracheostomies done for failure to wean in our ICU. So there's a lot of people looking at how can we shorten that time for anybody in our ICUs. I think we all realize that, with the pandemic, the ICU is being overworked, and can we shorten time people are on the ventilators? And that's really where a lot of my research is now, utilizing this type of technology to help anybody get off the ventilator earlier. And it's a much larger group of patients that we can help. And so it's obviously, I got another 25 years of research maybe. So I've been doing this for many years now. So we'll see.
So we're coming close to the end of our hour. What are the 3 points that people need to know about this?
Number one is that when being on a ventilator is life-changing, even if we can't get you off the ventilator, there's ways of handling that. And that's what many people say, well, if I can't get off, should I keep on going? Your brain is still working. It's just one aspect. The second major thing is that early is important, and you empower people over your long career in this. Ask for it. Say, I tell patients, it's in the guidelines, American College of Surgeons, it's FDA approved, it's available. Ask your people for it, and demand to get the care that really is on the leading edge. And people can. That's what I think is very important, especially if you have an acute spinal cord injury, or if your loved one has this. And probably on this phone, fortunately, on this phone call here, you probably have nobody that will, tomorrow will have a spinal cord injury in their family, but you may be contacted because this disease is. Asked for this early for your anybody that because that's really, in my mind, is the best benefit for these patients, is early implantation. If you see somebody who's been on a ventilator, and I've had this, that, well, I've been living great for 10 years on a ventilator, I've got my thing, I go, it's time for a change. And everybody I've done after years say, well, you're right, it is. Actually, it's good to do something new, right? Why am I stuck in this rut of being on a ventilator? That you can always find new rehabilitation, new technology that can help simplify you a little bit and will help you in the long term. I think it's relatively sad that we still have a fairly high death rate of people on ventilators. And this technology is here. And so I've given this talk at Asia and other meetings where there's not many diseases. In the United States right now, we have a problem with taking care of chronic ventilator patients, because there's not a lot of people that want to take care of them. There's not a lot of facilities will take people on ventilators. So our survival rate for a 20-year-old on a ventilator is worse now than it was 20 years ago or 10 years ago. And we really realize that this shortage of healthcare personnel now, shortage of some of the spinal cord rehab hospitals may only take 1 or 2 patients at a time on a ventilator. Well, if you're third person having an injury on Memorial Day weekend when you go out on your motorcycle or something, where are you going to go when those 2 beds are taken up? Is that we need to work on getting more people off the ventilator early so that they can get that necessary rehabilitation in that area. So.
Well, I will tell you this, if I ever need one, I want one. So Dr. Onders, remember that, because come find me wherever I am and put that in me, because it's a great thing. There's somebody who looked in and wrote in and wanted more information about the facts and figures that you had stated. So please look up Dr. Raymond P. Onders, and he has an extensive resume that has all kinds of articles. You can go to PubMed, you can get his articles and look on there. So he has a great deal of information out there if you're needing to justify something for an insurance company or whatever, but it is FDA approved. So that should make it a little bit easier now.
You can find my email very easily on the web too. If you email me, I'll usually respond, or my key helper, Mary Jo Elmo, which anybody's had diaphragm pacing, she's been working with me for 20 years on this project too, that we work as a team to answer as many as we can, just like the Christopher Reeve Foundation does. And I'm sure if you ask them, they'll get it to us also.
So thank you for this, because it's been very exciting. And I hope we've reached a lot of people. And I hope that people out in the world, if you know someone who's on a ventilator, or you work with people and you think, hey, this might be an idea, talk to them and give them information about this. So, more people can have this opportunity. But Dr. Onders, thank you so much for taking your time. It's very valuable. I know you're operating today, so I appreciate you taking your time to talk to us and to the community. It's really been wonderful. Quite my pleasure.
Thank you, Linda. It's always great to talk to you. I listen to your webinars at times. I love getting some facts myself. And the Christopher and Dana Reeve Foundation, they've been great over the years. I had the honor of knowing both Christopher and Dana. So I think this is so important to live on with their legacy of this. And I really thank you and the foundation for continuing your work that's helped so many patients over the years. For the littlest problem can be a huge problem until you get the answer from Linda, which is so important.
Well, thank you very much for that compliment. And thank you again for being on the webinar.